all. So today we'll discuss one of the important case which may come as a short case, that is tumor lysis syndrome. So sometimes if they want to discuss something else other than tumor lysis syndrome like febrile neutropenia or maybe hyperleukocytosis syndrome, so then you might get this as a long case also. When you get a tumor lysis syndrome as a standalone, the questions are very well like pre-framed, so no need to bother. So it's like a mathematics, it is a stepwise, so questions are going to be a ready recon kind of this one. So you will not get too much of deviated questions, but when it comes as a long case, so then you should be like aware of the in and around managing immunocompromised patient, invasive fungal infection, invasive fungal infection, neutropenic patient management, infection control policies, and all those things. Okay. So here tumor lysis syndrome will discuss as an like standalone entity, what questions you can get, how a case unfold in your exam scenario, whether it is a EDIC part 2, DM, DRNB, IDCCM, IFCCM, or any sort of like critical care exit exam, or for your practical purpose at the bedside. So in the emergency department, a 46-year-old female male, so previously healthy, non-smoker, present to emergency department with a 3-day history of fever, so that is around 38.5 degrees Celsius on arrival. So was having a history of malaise, generalized body ache, and increasing shortness of breath over the last 24 hours. So he also reporting a weight loss of 5 kg over the past 2 months. So was having some vague night sweating and progressive fatigue. So middle-aged male who presented with history of fever prodrome with a short history of the breathing difficulty and weight loss. Okay. So on initial assessment, so heart rate is 110 per minute. So BP is 100 by 60, respiratory rate is 28, saturating 88% on room air. So requiring like 4 liter of oxygen later to maintain the saturation of around 94%. So room air 88%. So on 4 liter nasal oxygen, so saturating around 94%. So he appears mildly confused. So his jugular venous pressure is borderline elevated, means JVP is visualized, even though you don't monitor the JVP. So in European exams, you might get this. Okay, so JVP looks like elevated. So bibasal crepitations are present. So there is a mild facial puffiness. So what is your initial approach to this patient? How will you proceed with investigation of this particular patient? So middle-aged male patient who is a non-smoker, presented with febrile prodrome, breathing difficulty since 24 hours, 5 kg weight loss, so requiring around 4 liter of nasal oxygen. So with facial puffiness and basal crepitations. Okay. So what is your initial approach? So as we approach any sort of critically ill patients in the ER or maybe in the ICU, airway breathing circulation. So immediate stabilization of airway breathing circulation is very essential. So airway and breathing, apply oxygen, that is been already like started with a nasal oxygen. So prepare for NIV or intubation if there is a clinical scenario is going to worsen. So monitor for worsening confusion or hypercapnia if it is having some sort of CO2 narcosis. So two wide bore cannulas, like BP is borderline systolic is around 100. So send the labs hand in hand. So CBC, renal function test including creatinine, urea, so serum electrolyte, sodium, potassium, calcium, magnesium, phosphorus, uric acid, so LDH, do an ABG, so send the cultures, okay, because fever history is there. So X-ray chest is very important because breathing difficulty. So start fluid, so with an isotonic saline, especially if you're suspecting tumor lysis syndrome. At this moment, so there is no clarity on tumor lysis syndrome, but you can go ahead with some sort of crystallite, maybe saline or maybe ringer lactate also. So continuous cardiac monitoring, especially if you have some thought process of hyperkalemia, you need to monitor with a continuous ECG and all. So check GCS. So pupils, consider head CT if further neurological decline is there. So rule out any hypoglycemia because patient is having a like confusion. So look for any rashes, lymphadenopathy, masses, because fever history is there. In a non-smoker, some sort of malaise, generalized weakness is there. So some tropical infection. So lymphadenopathy, because some breathing difficulty, facial puffiness, we are suspecting some maybe mass in the chest. So full body ultrasound or point of care ultrasound. Okay, just to get an idea about the volume status, do an echocardiography to understand how is the contractility, is there any pleural effusion, anything is there which is contributing to like breathlessness in this particular patient. So basically this is a general approach what we do when a patient came with like some sort of hypoxia, fever, and that of the breathing difficulty. So we started him on some sort of maybe some basic antibiotic. So this is the x-ray we got. Okay, so comment on this chest x-ray, what's happening. So if you see, this is the trachea here. Okay, mediastinum looks widening. So basically, so this is the frontal chest X-ray showing PA view, showing a widened mediastinum with a convex right paratracheal contour. So right paratracheal contour is like convex, suggestive of an anterior mediastinal mass. So trachea is slightly deviated, lung fields relatively clear, no pleural effusion, pleural spaces are clear. So are no pneumothorax. So like the impression, probable anterior mediastinal mass. So but we need CT for further evaluation of the confirmation. Okay, so next question examiner might ask before jumping into the tumor lysis syndrome discussion, what are the differential diagnosis for anterior mediastinal mass? You should know at least 3 4 as a DD for anterior mediastinal mass. So thymoma, thymic epithelial tumor. So lymphoma, Hodgkin's lymphoma or non-Hodgkin's lymphoma, usually an young adult, okay, or to an adult like a middle-aged person. So bulky mediastinal lymphadenopathy, so will be there. Along with that, what we call it as a B symptoms, means B cell lymphoma symptoms like fever, weight loss, night sweat. So high grade malignancy and rapid onset is the possibility in lymphoma. So germ cell tumor, teratoma, so substernal ectopic like thyroid goiter. So other causes like thymic cyst, so thymolipoma, ectopic parathyroid. Okay, so all these things are the differential diagnosis for like anterior mediastinal mass, or it may be some sort of the secondaries, that is the metastasis from primary somewhere else. So these are some of the differential diagnosis with their age, with their features. Okay, key image findings are clinical clues, so that you need to tell at least 2 3 points when they ask differential diagnosis for anterior mediastinal mass. So in the meanwhile, we got a ECG. So this is the ECG. So comment on this ECG, and we got a CT chest which shows an anterior mediastinal mass which is measuring around 6.47 centimeter. Okay, 6.5 centimeter anterior mediastinal mass is there. So this is the ECG. What's happening here? So ECG shows tall, okay, like narrow and peaked T waves. So where you get this tall, narrow, peaked T waves, so that is the hyperkalemia. So as we expected, potassium here is 6.2, phosphate is 5.6, calcium 7.1, that is total calcium. Uric acid is 9.8, creatinine is 2 milligram per deciliter, burn 52, LDH is elevated 1280, pH is 7.25, bicarb is low 16, lactate is 2.8 with PCO2 of around 33. So here comes we made, so definitely patient is having a anterior mediastinal mass with a CT picture with the electrolyte profile. So made a provisional diagnosis as T cell lymphoblastic lymphoma, okay, with high tumor burden because patient is having a spontaneous tumor lysis syndrome. So definitely this patient need ICU admission. We admitted the patient in the ICU. So basically middle-aged male, so who looks like having an anterior mediastinal mass, that is because of the T cell lymphoblastic lymphoma. So with a spontaneous tumor lysis syndrome. Here comes again the question. So define tumor lysis syndrome. So comment on pathophysiology. Okay, these are very, very ready questions you can expect. So what are the diagnostic criteria of tumor lysis syndrome? What are its limitations? See, you might able to tell the criteria, but examiner is interested to understand. So whether you know the limitations of the diagnostic criteria for tumor lysis syndrome. Very, very important. Okay. So how we are going to define the tumor lysis syndrome? It is defined as a constellation of metabolic disturbances so that occur when a large number of malignant cells undergo rapid lysis. Either it may happen spontaneously or after a therapy. Therapy may be chemotherapy, radiotherapy, or even just giving a steroid. So, which cause releasing of intracellular ions and metabolic byproducts into the bloodstream, leading to hyperuricemia, hyperkalemia, so hyperphosphatemia, hypocalcemia, and potentially leading to acute kidney injury and other organ damage. So this is how we are going to define the tumor lysis syndrome. It may happen spontaneously or maybe secondary to the therapy. If you see the pathogenesis, okay, so when there is a lysis of the cancer cells, there is a release of cellular contents. So these are phosphate, potassium, and one and cytokines, and the breakdown product of the cell itself is the DNA. So DNA breaks down the DNA, which release the purines like adenosine, which get converted into inosine, so then to hypoxanthine. So there is an enzyme, hypo means xanthine oxidase, so then that converts hypoxanthine to xanthine. So then again the same enzyme converts xanth into uric acid. So uric acid is a like non-soluble material. So it should get converted into soluble material, that is allantoin, which get excreted easily in the urine. So then one hand we have adenosine, at the other hand we have guanosine, which get converted into guanine, then to xanthine. So this uric acid, okay, as I told, so it can get accumulated. So then that leads to tumor lysis with a crystal nephropathy and all. If it is easily getting excreted, so then there is no like problem with the tumor lysis syndrome. So all these phosphate, potassium, okay. So then the release of cytokines, whenever there is a cell breakdown, so there is a release of the cytokines. So all these pro-inflammatory cytokines like TNF alpha, IL-6, okay. So IL-10, IL-8, all these things will cause vasodilatation, hypotension, inflammation, acute kidney injury that finally leads to the tumor lysis syndrome. So basically, when we have this uric acid, okay, so it is going to be markedly increased in tumor lysis syndrome because when it is having a problem with that of the excretion. So the precipitation of uric acid in the renal tubule can cause worsening of renal failure. It can induce renal vasoconstriction also. It cause impaired autoregulation, so it decrease the renal blood flow, inflammation, overall resulting in acute kidney injury. Uric acid is poorly soluble in water, so particularly in acidic environment in the distal tubules and that of the collecting system of the kidney. So overproduction and over excretion of uric acid in tumor lysis syndrome can lead to crystal precipitation, okay, so, and deposition in the renal tubule and acute uric acid nephropathy with that of the acute kidney injury. So, that is one of the culprit how patient can have acute kidney injury in tumor lysis syndrome. Okay. So, what is the diagnostic criteria? The famous Cairo-Bishop criteria. So, here two or more of the following abnormalities within 3 days before or up to 7 days after the therapy. Okay, 3 days before or up to 7 days of the therapy, two or more of the following lab criteria like uric acid of more than or equal to 8, so or more than 25% increase from the baseline, potassium of more than or equal to 6 or more than or equal to 25% increase, phosphate more than or equal to 4.5 or more than or equal to 25% increase, calcium the same, like it is decrease in calcium. So calcium less than 7 milligram per deciliter, less than or equal to, or decrease of more than or equal to 25% from the baseline. So with lab criteria, like we have a clinical TLS criteria. So lab TLS plus one or more of the clinical criteria, like creatinine more than or equal to 1.5 times the upper limit of the normal, or already having an established acute kidney injury, cardiac arrhythmia, sudden cardiac death, or patient is having a convulsion. So timing window, the abnormality should occur so in the period of 3 days before the therapy or 7 days after the initiation of cytotoxic therapy. So in high risk patient, so they might go for a spontaneous tumor lysis syndrome. Okay, so this criteria they included for Cairo Bishop, like TLS criteria, diagnostic criteria, but it is having lots of limitation. So exclusion of spontaneous tumor lysis syndrome is the first limitation. So the criteria are built around TLS occurring within 3 days before to 7 days after the initiation of cytotoxic therapy. So spontaneous TLS so may not satisfy the time window. So that is one limitation. Okay. So then the second limitation, requirement of 25% so change from the baseline. So the addition of 25% increase or decrease from baseline of electrolyte or uric acid value may be meaningless if baseline value already in the normal. So this may lead to underdiagnosis. Okay. So or if it is already elevated. So fixed lab cutoff is the one more limitation. Using fixed threshold like potassium of more than 6, so uric acid of more than 8 may miss milder yet clinically significant TLS in modern therapy setting. There might not be be 5.8. So then you are going to miss the diagnosis of TLS. Okay. So creatinine criteria insensitive. So the criteria for clinical TLS uses creatinine of more than or equal to 1.5 from the upper normal limit. So this fails to account for patients with already having a CKD, low muscle mass, or subtle acute rise in creatinine, which may not be more than or equal to 1.5 times. So again, the next limitation does not reflect modern therapy regimens. So the criteria were developed in older therapy context. So newer rapid acting targeted therapy may cause TLS outside the classic window. It may not happen 3 days before, 7 days after. So cannot distinguish TLS from other causes of metabolic derangement. Okay. So maybe it is sepsis with AK, so tumor necrosis, which may also have the same hyperkalemia, okay, hyperphosphatemia, hyperuricemia. So then this criteria may not help in differentiating from the other causes for metabolic derangement. Okay, so we have some grading. So examiner might ask, so it is being graded depending upon the value of creatinine, cardiac arrhythmia, seizure. Okay, so these are the complications. So they have graded into the 0, 1, 2, 3, 4 grade. So depending upon the value of creatinine, cardiac arrhythmia, seizures, so this grading you can just go through. So some examiners might ask, so Cairo Bishop clinical tumor lysis syndrome definition and the grading. Okay, very, very important. Next question, which malignancies have higher incidence of TLS? So what are the risk factors for tumor lysis syndrome? Do you think so solid organ malignancy will have tumor lysis syndrome? Very, very, very rare possibility. It is always with a hematolymphoid malignancy. If you see the list, so the TLS incidence and the causes, so acute lymphoblastic leukemia, ALL series is more common with TLS. So AML series is myeloid like series is more common with that of the hyperleukocytosis syndrome. Very, very important. Okay. So then is acute myeloid leukemia, little less. So non-Hodgkin's lymphoma, solid tumor, very, very rare. Okay. So much less common than the hematolymphoid malignancies, but some case reports are there. Overall, mixed malignancies in hospital data. So like in one of the large US based discharge based study, so non-Hodgkin's lymphoma, so corresponding to 30% of TLS, solid tumor 20%, we don't know. So AML 19%, ALL 13%. So this is the mixed malignancy hospital data. But otherwise, so ALL and that of the non-Hodgkin's lymphoma, Burkitt's lymphoma is the most common cause for the TLS. Okay, you can just go through the incidents. So there are some like malignancies, hematolymphoid malignancies, which have a high incidence of lab criteria which is satisfying TLS but may not the clinical criteria. There is a difference in the published data. So what are the risk factor to have a TLS? Okay, so there are tumor related risk factor, patient are like patient or organ related risk factor, therapy related risk factor. Okay, so if you see the tumor related risk factor, high tumor cell proliferation rate, so we call it as a tumor proliferation rate, large tumor burden or bulky disease, elevated baseline LDH already, high white cell count, especially in leukemia, tumor which is very sensitive to chemotherapy, highly sensitive like tumor, chemosensitive tumor. So patient related or organ dysfunction, already existing renal dysfunction, patient is volume depleted, dehydrated, acidic urine, oliguria or impaired urine flow, older age with a reduced renal reserve. So all these things are the patient related risk factor. Therapy related, use of highly effective cytotoxic chemotherapy or targeted therapy, rapid tumor cell kill, so including spontaneous lysis, use of steroid, immunotherapy, so CAR T cell in high tumor burden situation. So each tumor is having something called growth fraction. Okay, so if the growth fraction is more like proliferation of that tumor, more will be the burden of the tumor lysis syndrome. Okay, so like how would you start fluid therapy? We know that fluid is one of the important aspect in therapy of the tumor lysis syndrome. What type of fluid, target urine output and all. So remember, if patient is not having a spontaneous TLS, if you are planning to start chemotherapy maybe in the next 48 hours, so in the 36 to 24 hours prior only, it is better to start like IV hydration when you expect the tumor to have lysis problem and when you are expect to start the chemotherapy and all. So otherwise, initiate aggressive IV hydration with isotonic crystallite, preferably 0.9% saline. It is free of added potassium, phosphate and calcium. So approximately the volume is 2 to 3 liter per meter square per day. So that is around 3 to 4 liter per day in adult in high risk patient. So target the urine output of 80 to 100 ml per meter square per hour, which is around 2 ml per kg per hour, or at least 100 ml per hour in an adult equivalent. Okay, so monitor for the signs of volume overload like B lines and ultrasound, pleural effusion or crepitations are increasing the FiO2 requirement and all. So this is about bit on the fluid therapy kind of this one. So can you comment on potassium and phosphate binding agents and their limitations which we can use in tumor lysis syndrome? Very important. Okay, as I told, so examiner is interested to know your practical knowledge. So when which condition you can use potassium and phosphate binding agents and what are their limitations and all, very important. Okay, if you see for potassium binding agent, we have like sodium polystyrene sulfonate, so which is the cation exchange resin in GI tract that binds to potassium in exchange of sodium or sometimes to calcium in the colon. It increases the fecal potassium excretion. So typically the dosage is 15 gram or 1 gram per kg in children. So we can give 6th to 12th hourly depending upon the potassium level. So the problem is it is slower onset, risk of GI complication like bowel necrosis, especially when given with sorbitol. So monitoring is needed. So then we have so petiromer, which is a non-absorbed polymer that binds potassium in colon in exchange of calcium, and potassium is excreted through the fecal motion, that is the motion. Okay, so the dose is 8.4 gram to 16.8 gram once daily dosage we can give. So not for emergent life threatening hyperkalemia, slower onset of action, may bind other oral medications also. It's also having a GI side effect. So then we have sodium zirconium, so cytosilicate, okay, ZS9. So it is a crystalline compound that captures potassium in GI tract in exchange of sodium or potassium ion. So thereby it lowers the serum potassium. Often 10 gram orally, 1 to 3 times daily initially, then we give the maintenance dosage. It is also not for immediate life-threatening arrhythmia. So sodium load may be concerned in fluid overloaded patients. So long-term data is not at there, it is evolving. So basically these are all not meant for acute emergency treatment. That is very important. Okay. So that points you need to remember on the like all these potassium binding agents. What about phosphorus or phosphate binding agents? We have calcium carbonate. So we give a dosage of 500 to 1000 milligram elemental calcium with meals often one tablet TID with meals will use. So it provides calcium plus phosphate binding. Okay. So risk of hypercalcemia and vascular metastatic calcification is there. Okay. So that is a problem. So because when you give calcium, it may bind with the available phosphate. This calcium phosphate may become a crystal nephropathy and all. So calcium acetate 667 milligram tablet with each meal. So often one tablet TID. So lower elemental calcium than that of the carbonate, but also used with the meals. Okay, so that is a comment. So sevelamer hydrochloride or sevelamer carbonate. So the dosage is 800 to 1600 milligram orally. So 3 times daily we use with meals, and it is the dose adjusted as per the serum phosphate level. So it is a non-calcium binder. Initial dosing depends upon the serum phosphate. So the problem is, if the phosphate is very high, we need to give up to 1600 milligram. So 3 times daily. So it is a high pill burden will be there. So lanthanum carbonate initially 1500 milligram per day. So divided with meals. So most require 1500 to 3000 milligram per day. It is a chewable tablet. So take with or immediately after meals. So less elemental calcium load is the advantage. So then you have like sucroferric. So oxyhydroxide. So dose is 1500 milligram per day start. So 3 tablet with meal. So maintenance is around 1500 to 3000 milligram per day. So it is an iron based binder, offer lower pill burden. So stool color may change when you use. So sucroferric oxyhydroxide. So these are the like phosphate binding agents. Many students were not able to tell even a single phosphate binding agents when we ask them in the viva. Okay. So what are the therapeutic options? So we learned about fluid, we learned about phosphate, potassium binding agents and all. Next, we need some therapy which act as reducing the uric acid production and all. So we have two important agents. One is allopurinol, one is febuxostat. So both are xanthine oxidase inhibitor. So if you see this like pathophysiology, for just for completion sake, see here we have allopurinol which acts on xanthine oxidase inhibitor. So thereby it prevents the conversion of hypoxanthine to xanthine. Again, xanthine to uric acid conversion need xanthine oxidase. So here allopurinol will act. So but the problem is it can accumulate the xanthine crystal or it can accumulate the hypoxanthine crystal. That problem is still there. Either use allopurinol or a febuxostat. So Ras buricase is a recombinant uricase which convert non-soluble, less soluble uric acid into more soluble allantoin, and it get excreted in the urine, which we discuss later. Okay. So basically we have like two important like agents to prevent the production of like uric acid, that is allopurinol and febuxostat. So when it comes to mechanism, purine analog is the allopurinol. It inhibits xanthine oxidase via its metabolite, so oxypurinol. So febuxostat is a non-purine selective xanthine oxidase inhibitor. Both oxidized and reduced forms are going to be susceptible when you use febuxostat. So the dosage, so allopurinol 100 milligram per day starting, so titrated up to 300 milligram day per day depending upon the renal function. So febuxostat 80 to 120 milligram per day in adult. So lower doses, that is 40 milligram, is used in some setting in pediatric patient and all. So renal impairment, adjustment dosage, allopurinol required, but febuxostat less affected by renal clearance, so usable in many renal impairment setting without the major like dose adjustment. So remember, allopurinol renal is the concern. Febuxostat, it is having some sort of the cardiac dysfunction problem and all. Okay, cardiotoxicity. So reduction in serum uric acid. So allopurinol is effective, but in some comparative studies less potent as compared to that of the febuxostat at fixed dose. So febuxostat greater reduction in serum uric acid in some of the clinical trials at the defined dosage. Okay. Safety adverse event profile. So risk of severe hypersensitivity reaction like Steven Johnson syndrome, especially in HLA B positive population when you give allopurinol. So febuxostat better tolerable in some studies. Okay. However, cardiovascular safety is the concern, as I already told. Okay. Cost and utilization. Allopurinol is widely available. Long experience the clinician is having, lower cost. So febuxostat, so higher cost, often used when allopurinol is contraindicated, like in renal dysfunction or when it is ineffective. Okay. So use in tumor lysis syndrome or hyperuricemia. So common choice for prophylaxis, that is allopurinol. So because its onset time is very, very slow, it is not a very good option again when you need urgent reduction in uric acid. So you can use it as a prophylaxis before you expect the tumor lysis syndrome. So febuxostat may be considered when greater uric acid reduction is needed. So uptake in tumor lysis syndrome context, so less robustly defined. So but it is one of the option as a xanthine oxidase inhibitor that you need to remember. So this is the take home message. You can just go through it. So whatever I discussed, everything is here. So allopurinol, like not for emergency reduction in uric acid, so it is having a prophylactic role and not for renal dysfunction patient and all. When you use xanthine oxidase inhibitor, still there is a accumulation of hypoxanthine and xanthine, so still there is a possibility of the crystal formation. So that you need to remember. So these are the some of the take home points. Okay. So day 2, coming back to our case. So despite we given aggressive fluid of around 3.5 liter on one day. Okay. So we given initial insulin glucose therapy for hyperkalemia. So the patient become oliguric. So his urine output in the last 12 hours is less than 100 ml. So his creatinine is raised to 2.8, initially around 2. So he's on tablet febuxostat 40 milligram 12th hourly. Okay. So his heart rate is around 65 to 90. SpO2 is 90% on 8 liter of oxygen. Okay, now his oxygen requirement is also slowly increasing. BP is 96 by 66 borderline. ABG acidosis worsened, pH of 7.18, bicarb 13. Potassium is 6.9, lactate is 3.5. So calcium of 5.8 milligram per deciliter. Phosphate is 6.5. So we done again a repeat POCUS. IVC is full. So no variability in relation to respiration. He started having mild pleural effusion. So this is the ECG. There is a wide QRS. Okay. So merging into the T wave. So with the absent P wave. So this is what happening with the ECG, which suggests there is an significant impact of the high potassium value in terms of the ECG findings. So would you initiate renal replacement therapy at this level? So justify your answer. Yes, the patient is oliguric, his urine output is less than 100 ml in the last 12 hours. So rise in creat 2.8, persistent hyperkalemia, potassium is 6.9, acidosis, okay, with pH of 7.18, fluid overload signs, IVC is full, pleural effusion. So these meet the criteria of renal replacement therapy in tumor lysis syndrome. So early RRT can improve, can remove potassium, phosphate, uric acid, manage the volume status, so avoid the hypervolemia, and it may mitigate the further progression of the acute kidney injury. Okay. So suppose if you see, is there any data like CRRT versus other modalities? There is some data which favor the CRRT, but there is no head-to-head comparison. So studies shows that CRRT can correct derangement in the next 6 to 12 hours itself. So next question is, what are absolute RRT indication in tumor lysis syndrome? So refractory hyperkalemia, or when patient is having arrhythmia with a potassium of more than 6.5. So oliguria, anuria with a rise in burn and creatinine, volume overload which is unresponsive to diuretics. So our symptomatic hypocalcemia like tetany, seizure, elevated calcium phosphate product. If you are able to measure, if it is more than 70 milligram square per deciliter square, so despite an ongoing therapy, so these are the indication for renal replacement therapy in tumor lysis syndrome. Okay. So what are the options we have? We have intermittent hemodialysis, which rapidly remove the solute but may cause hemodynamic instability, and there is a possibility of the rebound like metabolic derangement. So SLED, slow efficiency, sustained low efficiency dialysis. So it's longer duration, gentle hemodynamics, so useful in ICU setting. Then we have a CRRT, best tolerated in unstable patients, So continuous solute removal, so less chance of rebound. So studies in TLS favor early CRRT, especially in pediatric and ICU setting. Okay. So in unstable patient when BP is 90-60 needing NORAD, so CRRT or a SLED is a favorable option. So the next question again in this area, do you continue fluid therapy? How do you monitor for fluid overload versus perfusion? Means when you start patient on RRT, so whether you are going to stop the fluid or going to continue, answer is yes. So maintain an hydration to promote solute clearance while on the RRT. So monitor urine output hourly, input output chart, daily weight. So chest ultrasound, echo for fluid status. So use the dynamic assessment like SVV, PPV, SPV. So pleural effusion, pulmonary edema signs you need to see, including the B lines. So examine for the effusion, crackles, B lines. Okay, use diuretics if patient is not under resuscitated, if is volume overloaded. So or go for the ultrafiltrate removal in the renal replacement therapy. So you need to balance between so clearing metabolites and avoiding the volume overload by giving volume excessive. So that you need to remember in mind. Okay. So patient's calcium is 5.8. So as we saw the value of calcium, so here it is 5.8 milligram per deciliter. So phosphate is 6.5. So what your junior like fellow done, he given a 10 ml of calcium gluconate 10%, given it over 10 minutes time. So is it a wrong or a right practice when we have a calcium of 5.8 milligram per deciliter? Okay, so what is your answer? Very, very important question. Okay, so remember, so treat hypocalcemia only if symptomatic, like patient is having tetany, seizures, or if hypocalcemia related ECG changes, arrhythmia and all. Okay, so routine treatment is discouraged because whatever you give the calcium with a high burden of the phosphate, it club with the calcium and form calcium phosphate precipitation in renal tubules that leads to crystal nephropathy and worsening of the so your acute kidney injury. So in this patient, potassium burden is, means phosphate burden is already high, it is 6.5. So then avoid prophylactic calcium unless patient is symptomatic or having a ECG changes. Very, very important question. Okay. So day 3, we initiated the dialysis. So SLED has been started. So due to oliguria and rising potassium and worsening acidosis, so initially on day 1 only we given rasburicase 0.2 milligram per kg IV. So on admission we given, now showing the uric acid level of 1.5 milligram per deciliter. So phosphate remains still high, it is 6.2, calcium is low, that is 6.9. So patient is sedated and started on mechanical ventilation because of increase in work of breathing. So his hemodynamics, his BP is 90/60, is on some minimal dose of NARD. So moderate dose of NARD, that is 0.05 mics per kg per minute. This is the day 3 of your tumor lysis syndrome. Here the question is, so can you comment on rasburicase, its clinical utility, how it function, what is its dosage, what is its limitation? Very, very important. So $1 million question for your tumor lysis syndrome. Okay. So rasburicase, if you see an overview, so it is the recombinant urate oxidase enzyme that convert uric acid into allantoic acid, which is more soluble metabolite. So clinical utility, so prevention and treatment of elevated plasma uric acid level in patients with malignancies like leukemia, lymphoma, or solid tumor. So at high risk for or with an established tumor lysis syndrome. Dosage 0.15 to zero point 0.2 milligram per kg IV once daily, infused over 30 minutes for up to 5 days. So single usage, single course only we can use. So key contraindication, remember when we have a known glucose G6PD deficiency, okay, glucose 6 phosphate dehydrogenase enzyme deficiency, it can cause severe hemolysis and methemoglobinemia. You need to avoid giving rasburicase. Okay, so then other problem is you need to monitor for the hypersensitivity or anaphylactic reaction. So these are some of the adverse effect, though we don't find a major problem with rasburicase, but rarely it can cause some sort of the anaphylactic or anaphylaxis reaction kind of this one, and cost is the concern. Okay, so practical consideration, ensure adequate hydration, Use chilled or aperonized tube for uric acid measurement after administering the Raspberry case. So otherwise we might get a error report of the uric acid. Use only a single course unless very specific circumstances. So prioritize use in high risk tumor lysis syndrome rather than routinely using this Raspberry case for all patients, because it is costly medication also. Okay, but this is the definitive therapy which helps in washing out the uric acid, convert it into allantoic acid, which is more soluble and is getting excreted in the urine. So next question, can you comment one therapy which we used historically in tumor lysis syndrome but currently not recommended, or why it is been not used now? What are its limitations? Okay, this is very important question again. So forced alkaline diuresis, what exactly it is? Okay, so it is a combined strategy of aggressive IV fluid hydration to induce high urine output, that is diuresis. So alkaline the urine, that is the next strategy. So typically by adding bicarbonate or using the fluid which is having a higher pH to increase solubility of uric acid and thereby promote the excretion of the uric acid. Okay, so third entity what we are going to club, if like hydration alone not helping in diuresing, so adding a loop diuretic to maintain or increase the urine flow. Okay, so the goal is to reduce intratubular precipitation of uric acid, that is a crystal nephropathy because of uric acid and other solute, and facilitate its renal excretion, okay, which is the lysate product of the tumor cells. Okay, rationality is very good. Give hydration, okay, give alkalize the urine and give diuretic. So how you do this? What is hydration part here? Start high volume isotonic crystalloid, that is normal saline. So target a urine output of 100 ml per meter square per hour or 2 ml per kg per hour in adult. So monitor input output strictly hourly. Okay. So urine alkalization, what you do is you add around 40 to 50 milliequivalent of sodium bicarbonate per 1 liter of normal saline or 5% dextrose, and give it at a dosage of 200 to 250 ml per hour, so that the urine pH is raised and maintained somewhere between 6.5 to 7. So this increase the solubility of the uric acid and it get excreted. So diuretics, if urine output remain insufficient, then you can use the loop diuretic like furosemide, okay, to force the diuresis. But again you need a monitoring of ABG, pH, intake, output, urine output, so all electrolytes including phosphate, calcium, potassium, uric acid and all. So we need to assess regularly for the signs and symptoms of volume overload also. This is the forced alkaline diuresis. But why it is not currently used? Why it's fallen out of favor? There are many reasons. Okay, so risk of calcium phosphate precipitation. So as I told, it reduces the uric acid crystal formation because it helps in making them excreted of this uric acid from the renal tubule. But on the other hand, so alkalizing urine raises the risk of calcium phosphate salt, so depositing in the renal tubule, especially when phosphate is high. So that is more common in tumor lysis syndrome, which may worsen the EK. Very important rationality why we don't use forced alkaline diuresis. So it is not effective for existing high uric acid or urate load. If uric acid is already very high or crystals are existing, simply alkalizing urine may not reverse the damage. It does not remove the solute load as effectively as dialysis or so urate oxidase therapy, that is the Raspberry case. Okay, if already crystal is formed, it's not going to remove it. So requires good renal perfusion and diuresis. If the patient has oliguria, anuria or any obstruction because of the urate nephropathy, forced diuresis may worsen the fluid overload or fail to clear any sort of the solutes. Okay, ultimately they need a dialysis. So evidence is weak in tumor lysis syndrome. So modern guidelines not recommend routine urinary alkalization. So like because we have advanced therapy like early dialysis or Raspberry case, that is recombinant urate oxidase. Okay, so risk of volume overload, high fluid volume plus diuretic in patients with background of cardiac dysfunction, already compromised renal function may provoke the pulmonary edema, and it may worsen the outcome. heart failure. So we need a careful balance of the fluid in these kind of patients. Okay, that's why nowadays we don't practice forced alkaline diuresis. Very, very important. Okay. So next question, what are the goals of dialysis in TLS beyond the volume management? So it helps in removing the excess potassium, phosphorus, uric acid and toxins from tumor lysis, control the volume, control the acid base management, so reduce the risk of further crystal nephropathy and prevent the AKI progression. So also it helps in preventing rebound electrolyte shift. So that may again cause hyperkalemia, hyperphosphatemia, hyperuricemia. So that is the benefit of overall benefit of the dialysis. Okay. So what other supportive therapy you need to do in TLS? So nutrition, ventilation, so fluid balance, okay, lung protective ventilation, monitoring, okay. Then we need a oncology, nephrology, ICU team coordination, because we need to plan renal support and targeted therapy for the tumor with an ongoing overall supportive care from the ICU. So that is very, very important. So with all the therapies what we do for phosphorus, potassium binding agent, fluid, rasburicase, okay. So with dialysis we need other therapy also in the intensive care unit. So day 4 we have some ECG changes. QTC still prolonged, T wave inversion is there instead of tall merged T waves with a QT or QRS. Okay. So this is the echo we got. So echo shows mild global hypokinesia. So diagnosis is mainly because of metabolic related myocardial depression. So plus or minus TLS induced stress myocarditis, because so TLS not only it is having a problem with dyselectrolemia or metabolic problem, it releases the cytokines. So all these cytokines can have some sort of the some myocarditis picture also, okay, with a global hypokinesia. So here on day 4 with all the therapy and dialysis, potassium is downtrend, so it is 5.2, calcium is improving 7.4, magnesium 1.4. So it's been started on beta blocker cautiously with slowly tapering up of the norepinephrine. Okay, so basically that is one of the therapy for stress induced so myocarditis. So if it is not purely because of cytokine induced like some sort of global hypokinesia, we can go for the beta blockers. So the question here is, what are the cardiac complications which we can look in tumor lysis syndrome? So arrhythmias because of hyperkalemia, like so peaked T waves, wide QRS, hypocalcemia, hyperphosphatemia. So myocardial depression due to electrolyte derangement or acidosis. So sudden cardiac arrest because of rapid shift in calcium, potassium and phosphate. So stress-induced cardiomyopathy may complicate ICU critically ill patient. Okay. So next, one of the question in relation to cardiac dysfunction is, how do you distinguish between electrolyte induced ECG changes or myocarditis? Okay. So rapid changes in ECG, if it is happening like within couple of hours, like T wave elevated or wide QRS, so which is again matched with the high potassium or calcium, and these ECG changes are reverted when you correct the electrolyte. So that is how we can differentiate. It is because of electrolyte related ECG changes, not because of myocarditis. Okay. So myocarditis, they have a persistent changes. So with elevated troponin, global or regional wall motion abnormalities on echo, sometimes persistent even after the electrolyte correction. So later we might require to perform maybe echo, cardiac MRI if you have a suspicion, still it is not clarified kind of this one. Okay. So otherwise may not require on routine, but if there is a cardiac dysfunction which is not explained by standalone electrolyte disturbances, then you can plan. So cardiogenic stent myocardium roll up by beta blockers. So if it is a stress cardiomyopathy, like a Takotsubo cardiomyopathy, so with a neurogenic some sort of means pulmonary edema is there, then we can go for AC inhibitor, angiotensin receptor blockers or beta blockers. So if hemodynamically stable, okay, we need to monitor thoroughly BP, heart rate and that of the so cardiac output with the invasive monitoring if required. Okay. So are there drug induced contributor? So like when patient is having a G6PD deficiency, if you give a rasburicase which can cause significant hemolysis and methemoglobinemia, which can again worsen the cardiac dysfunction and all. So other problem why we can have a cardiac dysfunction is if you chemotherapy which are cardiotoxic. So anthracycline, okay, adriamycin, daunorubicin based chemotherapy, these are all cardiotoxic chemotherapy. So these are all the reasons we need to look when patient is having a cardiac dysfunction. So on day 5, so there is a clinical improvement. Uric acid become normal 0.8 milligram per deciliter. Create down to 1.9 after 2 cycles of SLED. Urine output is improving. Now it is 1.2 ml per kg per hour. So patient is off norepinephrine. So is on 30% FiO2 minimal PEEP. So is GCS E4 VTM6. We stop the sedation and all. Okay. So is ready for weaning now. So is almost like treated case of the tumor lysis syndrome. So here the question is how we are going to plan de-escalation of therapy, because he was on rasburicase, so some binding agents and all. What are the criteria to stop rasburicase and that of the dialysis? So rasburicase, once uric acid is normalized, if it is less than 6 milligram per deciliter, tumor lysis risk has passed, like LDH is having a downtrending, so renal function improving, we can consider so switching from rasburicase to allopurinol prophylaxis. So dialysis, reduce the frequency or stop when urine output is sustained and it is more than 0.5 ml per kg per hour or more than 1 ml per kg per hour in this patient. Okay. So creatinine is downtrending, volume status is managed, there is no hypervolemia and there is no ongoing severe metabolic derangement. Then we can stop the or de-escalate the dialysis. So is there any indication for ongoing phosphate binders or uric acid monitoring? Definitely yes. So continue phosphate binders until phosphate level is less than 4.5 milligram per deciliter. So calcium phosphate product is safe at this level. Okay, when you have a low phosphate level, so monitor potassium, calcium, phosphate and uric acid also. So maintain the hydration and monitor the late relapse of the tumor lysis syndrome. Basically when you stop everything, so there is a still chance of so rebound or relapse of the TLS, because when you start the chemotherapy, the remaining tumor cells may rapidly lyse and it may again have a relapse kind of this one. Would you consider switching from rasburicase to xanthine oxidase inhibitor? Yes, once acute phase is over, so uric acid risk still remains. So because when we give an ongoing therapy targeting the tumor, again it may kick off. So better give allopurinol as a prophylaxis or other xanthine oxidase inhibitor like febuxostatin. So that is very important. Don't stop everything. So even though your burden of like uric acid is came down, but tumor is still there and you are going to start and continue definitive therapy for the tumor and it may again kick off the uric acid. That's why allopurinol should be continued. What is the discharge plan? So hydration, drugs, tumor directed therapy. Hydration may be like you can allow oral fluid, maybe total around 3 to 4 liter per day, monitor urine output. So avoid high potassium or phosphate diet. So drugs continue potassium or phosphate binders as a prophylaxis. Allopurinol prophylaxis, switch from rasburicase to xanthine oxidase inhibitor, monitor the electrolytes. So tumor based therapy, like when medical oncologist they plan continue the chemotherapy or the targeted therapy and be vigilant about the risk of TLS recurrence also. So follow up with a regular lab, creat, urea, uric acid, LDH, potassium, phosphate, calcium and the fluid balance and urine output. Very important. Okay. So this is an overview on the management of tumor lysis syndrome. So patient at risk of TLS. So serum uric acid you measure. If it is less than 8 milligram per deciliter, fluid allopurinol, consider rasburicase. If it is more than 8 milligram per deciliter, so definitely you need to give rasburicase with allopurinol because it's going to take time in starting its action. Follow the labs every 8 to 12 hours. Okay. So when you initiate all these things, uric acid is less than 8, it is fine. If it is still more than or equal to 8, repeat giving of one more dose of 0.2 milligram per kg of the rasburicase. Again, monitor all these things like blood urea nitrogen, creat, uric acid, phosphate, calcium, potassium, urine output LDH. So correct the hyperkalemia, maintain urine output of more than 100 ml per hour. So dialysis, if hyperkalemia, hyperphosphatemia, hyperuricemia, or acidosis, ECG changes, refractory volume overload, we can consider for renal replacement therapy. So this is about tumor lysis syndrome. So we'll come back with few more cases. Till the time, revise, recall, and practice at the bedside. Thank you.